Yeah, thanks so much for having me. This talk isn't industry relevant, but I do want to disclose that I tend to look at things through a deformity slant, even smaller degenerative cases, so that's kind of the person that's talking to you. I wanted to start with a case. This is a relatively frail 65-year-old woman who came in to me with a chief complaint really of flank pain, no really neurologic symptoms, but this pretty dramatic focal coronal deformity. Only a little bit of stenosis at L3-4. And standing films which demonstrate global imbalance sagittally, certainly a mismatch of the PILL. But really a curve, you know, the 5-1 segment pretty flat, the curve, not sagittally flat, but no coronal deformity through the 5-1 segment. The curve is an unusual curve. It almost looks like a neuromuscular type curve to me, and it's very focal at that lumbar area. So this is the kind of another example. I love that case that just got presented because fractional curve cases are a perfect discussion ground for do you go small, do you go big, do you go medium, and this too. You know, this got all sorts of different opinions we present all our cases at a deformity conference, and this had all sorts of different opinions applied to it. So this patient hasn't been operated yet. I don't have anything to show you on the other end, but I think it's a good table setting for the discussion that we're about to have. And of course, the bending films don't really fully correct out. So what does it mean? You know, this becomes a little bit philosophical. What does it mean to take a deformity approach versus a degenerative approach to our patients? I mean, does it mean everybody gets long films? Everybody gets a fusion. We try to affect structural change to these patients. You know, we're making a simple decision about a regional or segmental construct versus a T10 or a T4 to pelvis. Is that really what this means? Does it mean, oh, I have to use osteotomies or not? Do I have to, if someone comes in that's already had surgery, am I required to sort of undo the iatrogenesis that's so common in everybody's clinics from a structural standpoint? And then, you know, maybe it's a little bit more general. Maybe it's, hey, I really should be trying to restore spinopelvic parameters in everybody I treat, whether that's, you know, a limited structural operation or a big operation, or even just resolving stenosis that's going to help you get your parameters back in line because of their compensatory posture. And maybe it's as philosophical as, hey, deformity approach is about durability and long-term success of constructs that smaller constructs might work well for a couple of years, but you know what's coming next. And maybe a deformity approach as opposed to a degenerative approach is really about that. It's about the long-term outlook. So I think there's no real one definition, but these are some of the things that kind of came to mind when I was asked to give this talk. So when you see, but the real topic is how do we handle patients in the clinic? When you see a patient, I think the history is first, second, and third in importance on my list of how to distinguish between degenerative and deformity pathology. You really have to listen to the patient. You have to listen to what bothers them most. So back pain, if they come in with back pain, I mean, most people are aware that an extension-based back pain sort of indicates facet arthropathy potentially, whereas a flexion-based back pain indicates potentially a discogenic pain. A very booming, horrible back pain every time they stand up, which gets better when they sit and rest, can usually point to a neurogenic source of the back pain and stenosis. Certainly, rest pain, night pain, pain that gnaws at me all day, that's a red flag pain, and we start thinking about tumors and infections. But I think the deformity patients actually have a different kind of back pain. They have a back pain which it's a very fatigable back pain. It gets exhausting and achy at the end of the day. And why? Because they spend all day compensating for their deformity and they just wear out. So I think, you know, back pain is not back pain. That's the first thing we tell our residents and fellows, and we try to be more nuanced with what back pain is. Certainly you're gonna be examining people with a full neurologic exam. I think patients that have a really focal radiculopathy or achy bilateral crampy leg pain of neurogenic claudication, these patients are screaming that their neurology is the thing that's causing the problem. And usually that's correctable without some big deformity correction. So I think, the focal radiculopathies really take me away from a deformity approach. And then sometimes they'll just tell you, I can't stand up straight, I'm way off to the left, I feel off to one side. Very common for them to get bad flank pain, like that first case, as their rib cage sort of settles onto their ilium in coronal deformity. Really take a good history about their prior surgery. I tend to assume prior surgery was done poorly. I hate to say that, but there's so much sagittally poor surgery done out there that it's just so common, and I think you have to be on the lookout for it. If we're not fixing deformity, we are creating it, of course. So imaging in the clinic, I think it's impractical. We have EOS. I have to send a patient across the street to the main rush hospital from our office to get it. I think most clinics it's pretty impractical to get, full-length films on everybody. Some folks in this room may do that efficiently. I don't really think it's necessary, but I think you should have a protocol to be able to get these studies when you need them. But I think something that makes a little bit more sense to me is just like a really basic approach to understanding deformity principles in everybody. So what we tell our fellows and our residents is, the first thing we're going to start with is try to understand how is the sacrum set in the pelvis. That is pelvic incidence. Try to understand how the lumbar spine comes back and corrects the horizontality of that sacrum. That is lumbar lordosis, and that is the essence of PILL mismatch. If you just start there, then you can start to understand, okay, if I have a mismatch, where is the patient compensating? And there's a bunch of ways patients compensate for mismatch. Pelvic tilt, obviously one of the most compensatory things that patients do, but also thoracic hypokyphosis, cervical hyperlordosis. There's a bunch of different things that patients do, and I look for those compensation mechanisms because the compensation itself can be the source of the pain. And then, if the patient's decompensated, that's when you get into a global imbalance situation, and you have to decide, okay, are they recently globally imbalanced, or has this been a long-term chronic thing that's now fixed? So, in summary, with the imaging, I really start with the base of the spine and a parameter assessment on every patient, no matter whether they have a big, nasty-looking curve or whether they have a very simple one-level spondy. I don't think you need a long film on everybody. I think you need to see the hips on every lumbar x-ray, though, and that's not something that always gets done, so it's something we kind of set up in our protocol. Remember that the degree of stenosis will drive a forward flex posture. One of the really nice things to do in clinic is, and I know we have a parameter talk here coming up, but one of the really nice things to do is to compare the lumbar lordosis standing to the lumbar lordosis on a flat MRI. So it's not a commonly done thing, but if you measure, you take this patient where the lumbar lordosis is 24 degrees, very mismatched to the 48-degree pelvic incidence, but you actually just measure their lordosis in the MRI scan, it corrects. So really they're forward like that because of that horrendous 2 to 4 stenosis. He's got an old isthmic spondy, which I don't think is really playing a role. But with that bad central stenosis, they have this postural correction, and the X-ray to MRI lordosis is kind of one of the things that I think is really useful to get at that. And then if something doesn't seem right, this is another interesting example. This patient comes in, and boy, does that lumbar spine look incredibly lordotic, because they're compensating for something higher that you didn't see on the initial lumbar films, and that this is all a focal deformity because of compression fractures up higher that you'd miss if you didn't sort of cue in and say, boy, that looks hyperlordotic, and we have too much lumbar lordosis for that pelvic incidence. So we fix the focal deformity, and the patient stands up better and loses some of their lumbar lordosis. So physical exam, I don't underestimate the value of having the patient show you where the pain is. When the patient says back pain, they may mean flank pain, they may mean butt pain, they may mean tailbone pain. It's just all over the map. So really take the time to have them show you. Assess for hip flexion contracture. I think that can drive a lot of deformity, and it's really nothing to do with the spine. I take bolster or bending x-rays frequently to assess rigidity. And of course, observe the gait, because a Trendelenburg gait, a shuffling gait, a pitch forward gait, those really indicate other pathologies that may get you closer to actually helping the patient without starting to take them down a big deformity road. So I think, you know, with every big deformity that comes in, there's always the three bears options. I mean, there's a minimal decompression, there's a limited segmental or regional correction, or a full correction. And I'm very frequently talking to patients about all three of those options. I think patients respond really well to that. This is a super osteoporotic, bad looking chronic, you know, idiopathic degenerative, superimposed on idiopathic curve. With really all her problem was neurogenic claudication because of this one segment of stenosis. We do a simple one-level laminectomy and that's it. So I think, you know, there's very few scenarios where there's an absolute indication to take a big deformity approach, and I would highlight progressive curves, progressive sagittal imbalance. You know, these are patients we have to get to know and watch them over time, and then curves with high magnitudes obviously may force your hand. But I think that even in every case where you're sure it's just a one-level spondy, look at the pelvic parameters, rule out some decompensated global deformity. And honestly, it's hard to get into trouble by maximizing segmental lordosis. So every spondy, I mean, we're going to really try to improve the segmental lordosis as much as we can. I don't think it's much extra work. You know, people talk about, oh, there's so much morbidity to osteotomies. Yes, to 3-column osteotomies, but to do posterior column osteotomies and T-lifts, for me, is really not that much intervention. And I try to do it as much as possible because, you know, leaving patients with a better segmental lordosis is almost always helpful. Last case, you know, a patient with an MIS T-lift outside comes in, presents with severe adjacent segment disease. Parameters are really mismatched, so 19 of lumbar lordosis and 47 of pelvic incidence. And, you know, this patient should have 30 degrees of lumbar lordosis to get to 2/3 of their pelvic incidence, 4-to-1, and they have 16. So they're really fused flat, and they have adjacent segment. So how can we catch up? There's horrible stenosis at the adjacent segment. I did a T-lift, a cantilever T-lift as we call it, where the T-lift is put up front, and there's a bilateral. I don't do a full osteotomy. I leave the majority of one facet, but I loosen it and I drill it to the point where it's loose and it can accommodate a posterior compression, and then we'll compress off the cage. You can see that the parameters go from 19 of lumbar lordosis to almost 42 degrees just with that single level intervention. So that's kind of a degenerative-y case that we address in a deformity type way. So in summary, the clinic visit's an important time. You really have to drill down on what's bothering the patient, and that's going to drive your approach. I always try to manage patients with operations that are as small as humanly possible, but I try to keep the deformity principles in mind, so thank you.